Good evening to everyone. With warm greetings and best wishes from Dr. S.S. Hiremath. On behalf of Honorable President of Dental Council of India, I have a great privilege in welcoming all of you to the DCI platform of the webinar series. And today you are attending the 20th webinar series, and that too on the New Year Day. I would like to express my sincere gratitude and thanks to the Honorable President, Dr. Bharat Shetty, Secretary, Deputy Secretary, Executive Committee members, and all DCI members for having given me this opportunity to moderate for today's webinar. And I'll be definitely flailing a duty if I do not thank the entire DCI office. I'm truly humbled to be part of this program. Started as a global initiative, at the time of started as a global initiative by DCI, it became a most gratified venture to take up such useful learning platform for the benefit of all dental professionals. And this is to keep the positivity and vision of learning during the turbulent time of pandemic. This has taken up such an innovative creatives. Finally, I believe this is a unique venture by the apex body for having organized such kind of learning platform which is not there in any part of the world. These webinar series are going on very successfully since beginning by the contribution of excellent speakers of both national and international reputation. Now, there are some instructions for the attendees. Please go through all of them clearly. At the time of registration, complete and proper detail must be furnished since the same will be captured for general certificate and CD points. No request for any change or modification in the details shall be considered. An e-certificate of attendance will be conferred to all attendees, including undergraduate students, international attendees, and non-dentists on their registered email. CDE points will be awarded to the dentist registered with the state dental councils or tribunals of India. Certificates will be sent to the attendees by email within 3 days of conclusion of each webinar who have attended the entire session of webinar uninterrupted. Please check your junk email folder just in case the certificate email got delivered there instead of your inbox. In case of any query or issue, please drop email at webinardci@gmail.com. Now, as far as the getting access to the previous webinar, those people who are based at the would like to access it, please kindly go to the website of Dental Council of India and log into the webinar archives, and definitely you will get those particular things which you have missed in the previous time. Now, at the same time, you can go for a downloading the certificate and get the certificate of that thing. Please visit the DCI India website for more information. Now, at the same time, feedback link will be sent to you with a certificate email. I request all the participants, please fill up these feedback form and send properly. The reason is to improve for a future webinar series. We need your feedback information so that it will be very useful. Now, DCI has appreciated and recognized the highest attendance in the last webinar. There are 5 dental colleges, starting with Savita Dental College and Hospital, Chennai, Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Jananayak Devilal Dental College, Sirsa, MGM Dental College and Hospital, Mumbai, and lastly, Sharad Pawar Dental College, Wardha. Hats off to all these people who have made this very successful. Now, coming to today's the topic, tobacco cessation and dentistry, and presenter is Dr. Vikrant Mohanty. Now, I'll go for a short introduction of Dr. Vikrant Mohanty. Currently, he is Associate Professor and Head of the Department, Maulana Azad Institute of Dental Science, Government of NCT, Delhi, since 2009. Principal Program Coordinator at the National Resource Center of Oral Health and Tobacco Cessation Made, initiative funded by Minister of Health and Family Welfare. He is a medical officer in charge, mobile clinic project under NHM, first mobile dental clinic project in India. And now he is a recipient, though as far the academic achievements are concerned, he completed his bachelor's degree from KGF Dental College and Hospital, KGF, Karnataka in 2002, completed his master degree in public dentistry from STM Dental College and Hospital in 2006, and completed his MBA in Healthcare Administration from Faculty of Management Studies, Delhi University in 2014. Lastly, he completed his PG diploma in medical law and ethics from National Law School, India University in 2007. He is also recipient of the IGTC scholarship and completed the Global Tobacco Control Certificate Program at the St. John Hopkins Bloomberg School of Dental Public Health in 2019. I have a great pleasure in introducing Dr. Vikrant Mohanty, and I am going to welcome him for today's topic. Now, before going into the things, I would like to go for a brief introduction to the topic of today's, that is tobacco cessation and dentistry. The tobacco use is one of the leading causes of premature death and preventable illness. The extensive use of tobacco plays a pivotal role in increasing the burden of non-communicable diseases. Globally, tobacco kills more than 8 billion people annually, and unfortunately, the 80% of these deaths are coming from the developed, underdeveloped, and developing countries. And as far as the evidence says, dental professionals are in a unique position to help tobacco users in providing cessation assistance. Fortunately, there is a appreciated role of Minister of Health and Family Welfare, Govt of India, and DCI in expanding the scope of tobacco cessation from dental profession. Now, and I'm going for that particular thing. As far as this is concerned, I would like to hand over the mic to Vikrant Mohanty for going for a presentation.
Thank you so much, sir. I hope I'm audible to you.
Yes.
Yeah, thank you so much for your kind introduction. And before I initiate the topic, I would like to extend my heartfelt gratitude to the President Dental Council of India, the esteemed EC members, as well as the governing body members, and the team which has been responsible for bringing these webinar series to your homes. This is Dr. Virendra Goel, Mr. Mukesh, and Mr. Kushal, the technical team who has been involved in this. And at the same time, I'm really honored to be allowed to be presenting this particular topic to you. So moving on behalf of the faculty, staff, and students of Maulana Azad Institute of Dental Sciences, Delhi, I would like to initiate this webinar. All of you must have seen this topic, this image particularly, and could relate many perspectives of life through this particular image. So when I look at it from the context of tobacco cessation, I look at it as all of us working towards something, but still not being able to identify it holistically. So this is the story of 6 blind men and their experiences with an elephant. So all of them have actually felt the elephant at different parts and visualize it as the elephant, as a snake, as a trunk of a tree, as a fan, and else similarly. But when I look at tobacco cessation, it's not new for all of us, because all of us have somewhere or other have actually provided cessation services. Somehow it is going amiss. We do not look at it as an overall. We have had certain successes, but still we are way behind the numbers. So today I will be talking to you about tobacco cessation in a more comprehensive manner, trying to highlight how exactly cessation can be integrated, and more than cessation, what else can be done. So we need to be aware of it, and I will be going, helping you, guiding you through this whole session. So I would be dividing my session through these sections. To introduce the topic, I am very sure tobacco is something which does not need any introduction to any one of you. But still, tobacco remains the most legal drug that kills many of its users when used exactly as intended by its manufacturers. It is a very beautifully, scientifically engineered, legal drug which causes death. More than 8 million people globally die every year because of tobacco and its impact. In India itself, 3,500 deaths are there every day. 7 million deaths are mainly due to direct tobacco impact and almost 1.2 due to indirect use. When we look at the recent Global Adult Tobacco Survey, which is the standardized approach in which the information is collected in our country, there are other surveys also. The recent survey conducted in 2016-17, brings into picture that almost one third of the Indian population is consuming tobacco. Though this is 6 points less than the previous survey, that means that control measures have been in place, but still 28.6% of the population is consuming some form of the tobacco. It is very alarming that smokeless tobacco remains a huge burden in our country and in the Southeast Asia region. Another significant problem which is the dual users, that is use of both smoke as well as smokeless form. So it becomes even more difficult, and that is how we need to understand that certain problems of tobacco use are limited to certain parts of the world as well as certain parts of our country. So we need to know this and accordingly plan our interventions. If you look at this image, this is a beautiful image which talks about common risk factor approach, wherein there are common risk factors which manifest and contribute into many of the non-communicable diseases. If you look at tobacco, it is one of the vital and most important risk factor which is responsible for almost all types of diseases, whether it is cancers, whether it's diabetes, whether it's other NCDs that we're talking about. So control one risk factor, control the outcome of many diseases. So that's what we have to keep in mind when we talk to our patients, when we convey messages to our patients. These are concepts that we need to keep. It is important that we realize that there's a burden, there are common risk factors, and then there are economic and financial and social aspects of tobacco use. If you look at this particular report by the published by the Government of India on economic impact of tobacco use, almost 1.4 lakhs crores of people have spent money on their health related expenditure due to tobacco use in 2011. If you look at the same figure, almost just 17% is the central excise revenue that has been generated, the cost they have incurred towards their health. If you go a little bit more into the details of the GATS report and look at what is the current tobacco cessation status, you would see that 55.4% of the current smokers are thinking of quitting the habit. The reasons could be many, and only 48% of them have actually been advised by a healthcare provider. If you look similarly on the smokeless side, only 9.6% of the people are thinking about. So here, there are many things, the figures may not actually communicate the actual problem, but still, it is important we look at these problems. And only 31.7% of them are thinking about quitting. That means there's a huge amount, thinking about quitting who have been advised by healthcare providers. So there's a huge, opportunity lying there. At the same time, there's a huge opportunity of people who are seeking or thinking of seeking care. So is one single strategy enough? It isn't. It is important that we work towards integration of tobacco cessation into other health programs. Tobacco control measures could be unsuccessful if cessation is not integrated and made accessible to the people at large. Evidence mostly that we use is from the Western literature, and there are not many studies which have actually contributed in evidence. So that means best practices from there may not be implementable or workable in our country. So we need to develop best practices as well as principles which work in our country. So with this I conclude, and I would say the first section wherein I told you more about what the problem of tobacco is. But is it the actual picture of what tobacco the problem is? No, it isn't, because there is something which we need to understand. Tobacco as a habit is, there is something which is more than something which is more. That is the nicotine which is responsible for causing the addiction. When we look at it, it is other than nicotine, there are other behavioral aspects that individuals actually associate when it comes to tobacco use or quitting. Why do people not quit? The main problem is that tobacco is actually used as a primary coping mechanism by many. Coping for stress, coping for work-related aspects, for concentration, for many aspects, I would say. Also, lack of awareness for managing withdrawal symptoms and craving, the fear of that results in they not quitting. Many people have fears of being alienated from friends. People use tobacco as a mode of self-reward, and sometimes people do have this belief: everyone has to die someday, so why not use tobacco and die? At least you've enjoyed your life. That's what they feel. And then jungle belief is there, wherein everything in the world causes cancer. So tobacco also causes cancer. So these are the beliefs that we have to keep in mind. It is very important, because we just think that it is very easy to break the habit and provide cessation support. No, there is a lot of behavioral component we have to keep in mind. Other than that, we have to be very aware that nicotine is a very strong and potent addictive substance. Nicotine dependence has been classified under the DSM-5 and as well as ICD-10. Nicotine, when delivered through either smoke or smokeless form, reaches our brain and activates the nicotinic receptors. And these receptors actually release dopamine. And dopamine, once released in your brains, has a sense of calmness, produces a sense of calmness, a sense of relaxation, as well as there's a burst activity. The pleasure circuit is complete. So when these these dopamine levels go down again in the blood, there is something like nicotine pangs. The body demands for more nicotine. As a result of which, symptoms of withdrawal, anxiety, and stress are there. So what does an individual do? Again takes in tobacco. So this is a cyclic process. We need to break this cycle. First of all, understand this cycle and then work towards breaking this cycle. So dependence has it has two components which I will be talking about here. It has more dimensions, no doubt about it. So the dependence is mainly physiological as well as behavioral. The physiological component of dependence is mainly through nicotine, and it is the release of dopamine, because which is triggered due to nicotinic receptors, is what we have to address. At the same time, an individual actually relates or associates a lot of behavioral component to tobacco use, whether it is friends, whether it is stress, whether it is situations which are which desire a reward. So these are things that, or emptiness can also result in tobacco addiction. So these are things which are beyond just nicotine, which are also there. So when, as a dental professional, we have to understand that we have to address both the physiological component as well as the behavioral component. There could be other underlying mental disorders, other medically compromised situations which could also result in dependence. But that's something which we can look into more in detail later. But something which we have to keep in mind is keeping the physiological aspect as well as the behavioral component. The physiological aspect is taken care with the help of medication, and the behavioral component is mainly through the behavioral interventions that we are going to discuss in some time. So with this, we conclude the section 2 and we move on to what dental professionals can do when it comes to cessation. I know that we might have missed the opportunity. As I told you before also, dental professionals have been doing cessation. It's not something new, but still I feel somewhere we have missed the link somewhere. We have almost 313 dental colleges, 26,500 dental graduates coming out every year, more than 6,500 postgraduates coming out every year, but they are not being guided, trained in a systematic manner. Almost 2.7 lakhs dentists are practicing in the country right now. It has been reported in one of the studies that almost 25% of the patients reporting to the dental OPDs in hospitals consume tobacco in some form. Of that, almost 43% have some oral mucosal lesions. So it is important that we stop and we relook at what our strategies have been towards tobacco cessation as dental professionals. So we do a SWOT analysis for that. We understand what are our strengths, what are the opportunities, what are the challenges, and what are the threats. When I talk about strengths, I don't think so I have to go into detail telling you what strengths we have. But still, let me reinforce this at this point of time, that the signs of tobacco can be clinically and visually seen by the dentist first. And there we stand as a very good, strong contender to provide cessation. We can plan comprehensive treatments. We can plan personalized care for the patients. We can engage in multiple visits during dental care and use the chairside time for providing cessation support. We also understand that oral health is related to the quality of life. So it means that if you're able to improve the oral health, there is an indirect effect to improve the overall quality of the individual. You as a dental care professional can provide, you can build a trust and confidence, and that is why patients keep coming back to you for dental care. Also, dental clinics are not limited, do not have stigma. Why we talk about stigma? Many a times patients were actually referred to psychiatric hospitals or larger cancer institutes for cessation support previously. The dental clinics are not associated with stigma. Also, the follow-ups are much better when it comes to dental professionals. The opportunity is high because tobacco users have, there's a lot of dental problems that they accumulate. And the chairside time can be utilized very well when it comes to cessation support. We look at the challenges. As I already told you that the research mainly is from the Western world. So we need to have more dedicated research, clinical trials, interventions using current local methods, as well as methods which have been proven in the Western world applicable whether in our country or not. So we need more dedicated trials for that. Lack of knowledge among dental professionals to systematically follow a particular strategy. So we need training towards it. Lack of time, because dental professionals, when working in clinical settings, are very busy with their own patients. So dedicating time separately for this would be difficult. So it is something which we have to keep in mind. Also, the lack of financial reimbursement. No one is able to think about what could be a particular amount and why would a patient pay for that. So these are things which you have to keep in mind. And also, in case if I am not able to help as a dental professional, can I refer the patient to someone? I don't know where to refer the patient. So we don't have a strong referral linkage in this whole system. And no one walks into dental clinic saying that he wants to quit tobacco and can we help. So we need to work, understand these challenges and work towards these, overcoming these challenges. So moving on, what does the evidence say? Dental professionals are in a unique position to help tobacco users for providing cessation assistance. There's enough evidence which talks about how the odds are towards favoring the dentist. So we need to understand that the skills we have are unique. We need to use these skills to complement our cessation support. There is a possibility of integration of treatment into oral health as well as a dentist. The most important point is we are in contact with all age groups. We can use the chair set time as a teachable moment. We need to sensitize our patients that dental treatment outcomes are actually, are interfered because of tobacco use. We can schedule the follow-ups well and make them aware about the economic cost of tobacco use. So how do you exactly do it? Let's move on. There are two components mainly which we use for intervening. That is, one is the behavioral component, one is pharmacotherapy. Okay, the behavioral component is, first we need to understand that does tobacco cessation work. Less than 3 minutes of cessation, services which are provided have also generated some form of good cessation rates. And if you're able to provide in more time, you will see that there is even better results. And more the number of sessions, that is more the number of follow-ups, better are the outcomes. And if you integrate group sessions, the outcomes would be even better. Group sessions would be either you can use different type of tobacco users into groups and discuss their issues as well as provide solutions which are applicable to each other. So we do that regularly in our clinics, wherein we use this kind of intervention, wherein we bring in a patient who has undergone 3 sessions and a newcomer into the clinic and allow them to interact as well as we are there to orient the discussion. So it happens that these kind of locally relevant sessions would make cessation a much better experience for the patient. If you look at the pharmacotherapy, there's enough evidence, again mainly from the Western literature, which talks about how pharmacotherapy actually has increases the odds of quitting the habit. But we need to understand that every individual goes through a certain amount stages of changes before he actually comes to a particular behavior, whether it is forming a behavior or whether it is coming out of a already established behavior. So these stages are very beautifully described in this trans-theoretical model of change by Prochenska and De Clemente, which talk about how an individual moves from pre-contemplation, contemplation, preparation, action, maintenance and relapse. So pre-contemplation is one when he is totally not even thinking of quitting the habit. When you're talking about a patient who's being motivated to quit the habit, he's not even thinking about it. So he is already practicing his habit. It is important that we create opportunities through different channels so that he thinks about it, whether it is from the family, whether it is from the media, whether it is from the healthcare provider. From all sides, we're able to create this environment wherein he's thinking about quitting. Once he's made aware of the problem that exists with no commitment to action, that is what is contemplation. He is now started thinking about this. So what I would say is, once we move from contemplation, we start creating more opportunities for preparing him to take action towards addressing the problem. And how that can be? That can be, for example, you can intervene here with the help of, as a dental healthcare professional, you can gain access, provide him details about his current health status and try to motivate him to move from think about it and then prepare his environment, his family, his friends, his whole workplace to change and take action. So the action would be active modification of the behavior. He would either remove the various tobacco products from his environment. He would either inform his friends who are tobacco users that he would not be coming and joining them any further, or he would be identifying newer friends, or he would be managing in different ways so that at least he stays motivated and stays away from such cues. And this here, from action to maintenance, we also we take the help of medication. So sustained change can only happen when the new behavior is replaced by the older behavior. And many a times it happens that tobacco users actually go into relapse. They might have 1 or 2 lapses and then go into relapse. or in case if they are maintaining their quit status or maintain the sustained new behavior, that is staying quit, they can have a complete abstinence or abstinence stage. So this cycle of change is not a uniform pattern and goes back and forth before the new sustained behavior is actually established. So it is important that we understand, and if we talk about timelines of these stages, it can vary depending on the motivation of an individual. It can vary from 6 months to 1 year and even more than that. Patients can go back and forth, and that's why it's called an upward spiral. If you look at this change in this particular dimension, you see that the patient will only move from pre-contemplation to contemplation when the conscious is raised. He's socially liberated. That means he has to think of coming out. He has to think the family has a problem because of his tobacco use. The friends who are there are not the friends he is looking for. So he needs to understand this and liberate him from that. There has to be certain emotional arousal also, because in case his current health status is because of his tobacco practice, he needs to be told about that, and that should be made clear to him. So there might be an emotional arousal there, as a result of which he might quit the habit. He needs to relook at what changes he has made over this time and how these changes have actually supplemented his quit habit and ultimately have actually led toward a particular stage of his tobacco practice. And what is his commitment from here on, whether he remains committed or he goes back. So this is something where we're talking about going back and forth. He needs to see the rewards. These rewards need to be told repeatedly or reinforced regularly so that he is moving towards the rewards. And we should also look at what are the things which are countering, what are the environmental countering factors, whether it's friends, whether it's stress. We have to look at those counters also, and what his environmental factors are playing around him, and also understand how his relationships with his family, his children it is. Because many times parents have gone on to quit the habit because the child has been having certain problems. So these are things which we have to keep in mind while we talk about cessation as a strategy or bringing about this change in an individual. Also, this is another strategy which we use, is the use of risks and benefits. So we normally, we talk about this when we talk about there are many health risks and benefits an individual can face. But when we talk about oral health, it is very clear we have to talk about specific problems related, not scare him, not use fear tactics, but at the same time be careful while we use these strategies. But it's important we tell him about the risks as well as benefits of the habit particularly. So what do we do? So the first thing is develop a quit plan, and we use an acronym called STAR. That is, set a quit date, tell your family and friends, anticipate challenges of the upcoming quit attempts, and remove tobacco products from the environment. Set a quit date. You need to do it ASAP, as quickly as possible, as early as possible, as soon as possible. Because this would allow you to do a focused strategic approach and you will remain motivated. If you delay or keep postponing it, there might be a possibility that you might overlook this. So it is important that you set a quit date with the help of your patient, with the help of a dental professional in the next 2 weeks. And what you can do is you can schedule your dental treatments accordingly within that time. Tell your family and friends. Motivate the patient to inform his family and friends about that he is trying to quit and trying to make this change in his life. And it is important that the lifestyle changes also contribute into an individual's quit plan. Anticipate challenges. It is very important to educate individuals or tobacco users about the withdrawal symptoms. I know many of you would have played Super Mario, and many of you realize that Mario's only objective was to go and rescue the princess. There were many challenges. He would many times fail, but always come back to rescue the princess. So it is important that you understand that the patient has to be a Super Mario. There could be many quit attempts before actually he reaches the quit status. Remove all tobacco products from the environment. Minimize the tobacco cues. Minimize those tea breaks, those things which aggravate or expose oneself to tobacco. So how do we do it? So other than setting up a plan, we need to use certain behavioral strategies. And these strategies are mainly classified as 5 A's and 5 R's and frames, and then many more methods which are also available. The most popular methods are the 5A and 5R strategy which we use. We ask, advise, assess, assist, and we arrange. So if you look at this algorithm, you need to ask every patient about his tobacco use. In case if he is not using tobacco, so it's very important that you congratulate the patient, you encourage him to stay abstinent from here on, check every encounter from there on, and also ask him to stay away or from environments which are more exposing him to tobacco use. If you look at the 5A technique which we're talking about, it is, as I told you, we have to ask, advise, assess, assist, and arrange. So ask systematically every patient walking into your clinic regarding tobacco use. Make it a habit, make it a part of your routine. Okay, so and mention it clearly. You can flag it also. When you advise, you have to advise all tobacco users to quit. So there could be different strategies here. I told you about the 5A strategy. There's some modifications to 5A also. It is called the 2AR strategy. In case you're in the screening, you're screening the patient, you can ask, advise, and refer the patient, or else you can use ask, assess, and advise. 3 components you can use. So there are modifications to this. We will be talking mainly about the 5A technique. So when you're advising a patient, be clear, be strong, and be personal. Personalize the information which you're providing. When you're clear, it is very important to convey the patient that clearly that you need to quit the habit. And quitting is very important for you, and you are there to help him. When you personalize it, you need to tell him that his current dental problem is because of his tobacco use. For example, you have a young patient walking into your clinic. So if you tell him that in 10 more years of your tobacco use, you will have early wrinkling and you will age faster than someone of your own age who is not using tobacco. So when you use such cues for patients who are actually, use it, personalize it to their own problems, it becomes more easier for them to understand. So as a dental healthcare professional, you need to use these strategies. There are many strategies that we can talk about. 2 I have just presented in front of you. One is the cost calculator, in which you can see that on the left hand side is that what we have done is, if an individual spends 15 rupees per day, he goes on, if he is a user since last 10 years, he may be a rickshaw puller, maybe a daily wage laborer. For him, 60,000 rupees could be a huge amount. Similarly, if a smoker is there who spends almost 10 cigarettes a day, he goes on to spend almost 3.5 to 4 lakhs a year on smoking, on the last 10 years on smoking. If you equate this cost that they have incurred to what things they could have bought, that could be a good way of presenting it. Other than that, you are not even talking about the cost that he has incurred to visit your dental clinic or visit a hospital, and the number of visits he has made other than this for his healthcare. Okay, and other than that, you're also not talking about the days that he has lost from work because of ill health. So this is one way of doing it. Other than that, we have something like a decisional balance sheet, wherein we talk about the various pros and cons of continuing the habit, and when he quits the habit, what are the benefits that he would gain if he continues, what are the disadvantages he would disadvantages he would gain would happen because of continuing the habit. Similarly, if he discontinues the habit, what would happen? Next is assess. So you need to assess the readiness to quit. So readiness to quit is actually mainly demonstrated through two strategies. That is the importance that the patient relates to tobacco use, and the optimism that he has towards quitting the habit. Okay, it is very important that the patient is able to realize that it is necessary for him to quit this habit, and he should be optimistic, so that he should be motivated. He should be he has his plan laid out and work towards achieving his plan in a strategic manner. The other ways of assessing, which is very important for your treatment planning, is to use the scales of nicotine dependence. There are many scales of nicotine dependence. The most internationally accepted and validated tool is the Fagerstorm nicotine dependence scale. All these scales help us to quantify individuals' dependence, which is a more of a behavioral component, into a more objective way. And this dependence scale allows us to plan his intervention further. When it comes to pharmacotherapy, I will talk to you how these numbers do matter. So nicotine dependence scale by Fagerstorm gives us the rating of highly dependent, moderately dependent, and minimally dependent. Assist is the 4th step. I've already told you, how do you assist as a dental healthcare professional? You use the STAR strategy. Set the date, tell your family and friends, understand that there will be challenges, and remove all the cues of tobacco around you. Okay, the STAR component. So provide practical counseling. Provide strategies which are more unique, or which are very relatable for the individual. For example, if a person who's involved in smokeless tobacco, for him it is not just chewing which matters for him. It is the whole process of mixing the tobacco, sharing the tobacco, and consuming the tobacco. So you have to understand that this person needs to be told about this. So replacements can be given in the form of fennel seeds, in the form of elaichi, cardamom. So you can provide him solutions which are more day to day. Many a times patients go and the individuals go and buy tobacco from a particular shop. So it is very important to make them aware that they need to change the way how they go to a particular place. So that might also allow them to think about it, about quitting. Think about providing interest treatment social support. Many times we don't think that family can be helpful when it comes to such interventions, but yes, it can be. If families can be brought in, and during the second or third session when the patient is more comfortable and trying out, the family support also complements the overall outcome of the result. It is important to also share supplementary material to the patients. For example, the presence of quit lines today in our country. I'll talk about this in the later stage, about how to use quit lines and where they can call, and also recommend medication to these patients. Don't see, behavioral intervention is surely the key, but you can complement it and integrate pharmacotherapy, which I will be talking later. One more very important thing is, many a time dental professionals talk about quitting, talk about how its impact of tobacco users on oral health, on periodontal health, on different aspects. But it is important that you as dental professionals understand that every habit has certain withdrawals. Similarly, tobacco has its own withdrawals. So what are the withdrawals? You need to be educated first. You need to know that these are the various withdrawals that an individual could face. Let me tell you that all the withdrawal symptoms do not manifest in one person. There would be a combination of 2 or 3. Also, you need to know that the withdrawal symptoms actually, there's a pattern of how the withdrawal symptoms actually start coming into an individual's life. So within the first 2 weeks are where the withdrawal symptoms peak, and they remain mainly on the high till the first month. And by the end of third month, on an average, they go down. So if the patient is able to sustain with the help of counseling, behavioral intervention, as well as pharmacotherapy, we will be able to address the withdrawal symptoms. The various withdrawal symptoms are irritability, fatigue, insomnia, cough, nasal drip, hunger, headaches, and craving. When we talk about craving, it is one of the very unique strategies that we use is the 5D technique, wherein we delay. The first thing is delay the urge of consuming tobacco. It could be because of stress, it could be because of friends, it could be because of an environmental issue. So there could be many factors which play. So whenever such a situation arises, it is very important that you delay or make it wait. Make the situation wait. How do you do that? You can drink water, sip water slowly, hold the water in your mouth, deep breathe, practice breathing in and breathing out, repeat the cycle for 5 to 10 times, and you would see that there would be the urge of your, the craving which you have towards picking up a cigarette or taking up a chew or a dip would again go down. Distract yourself. Distractions can be many ways. You have to know what could distract you. You can call a friend, you can focus on tasks, you can move around, take breaks, and also discuss with family, friends, and your dental healthcare professionals. The last step is to arrange follow-ups, because dental patients more or less need multiple follow-ups. We all know that. So it is important that we use this opportunity, that integrate dental treatment to every follow-up visit that can come. If you can see in the second picture here, that the father who was a tobacco user was in our clinic, wherein we used social support and we arranged social support for the individual. So it is important that we use different patterns of approaches while we use, we arrange these follow-ups. Or telephonic follow-up is also convenient. In today's COVID times, telephonic follow-up could also be a way of intervention. Refer the patient for specialist support if it is needed. Know where is the nearby psychiatrist, or where are the de-addiction centers nearby where you can link with, or any other medical professionals who could actually assist in providing further interventions. So with this, we will actually we have spoken about an individual who is motivated to quit. I missed out on that. He is motivated to quit, and we use the 5A strategy. In case the patient is not thinking or is not motivated to quit, so we use the 5R strategy. The 5R strategy is relevance, risk, rewards, roadblocks, and repetition. When we talk about relevance, we need to understand that we need to make cessation relevant to his current problem. That is his dental problem, whether it is any other work-related problem. So we need to make it relevant to the patient. And then also think about what are the long-term and short-term risks that the individual is having. Think about the benefits that the patient would gain when he quits the habit. We always think that it is so easy to quit. Why doesn't he actually quit the habit? But there are roadblocks. It is important to identify these roadblocks, work out ways. As a dental care professional, when you're talking and counseling your patient, you have to work out these roadblocks. So you have to build a rapport with your patients. Okay, and that it has to be based on empathy. And repeat, always we think that once instruction given is done. No, you need to understand that the instructions need to be repeated, have to be comprehensive and simple, something which the patient can actually use. Okay, so with this we complete the 5A and 5R strategies. We have to also keep in mind lapse, relapse and abstinence. Lapses are something, but where it is one or two, it is just a slip. That is one isolated event of smoking when he started quitting. And relapse is something wherein he has gone back to his usual habit after 7 consecutive days, or on average goes back into complete usage of the same product. And abstinence we only consider at the end of 12 months, and only when we are able to quantify that he has quit the habit. And how do you quantify? I'll tell you further. So this is what we talked about, the behavioral intervention. Moving on to the pharmacotherapy, I would mainly talk about mainly the nicotine. There are 2 types of interventions in pharmacotherapy: the nicotine replacement therapy and the non-nicotine replacement therapy. We have to be very careful while we choose our various pharmacotherapeutical approaches, and keep in mind that combinations do work, but bupropion and varenicline preferably prescribed under medical supervision. Nicotine replacement therapy is something which you can do on your own. So it depends on, again, the dependence, as I told you. All medium and severe dependence on the basis of Fagerstrom or other scales can be given, should be given a pharmacotherapy with NRT. And any failed attempts, you need to give them. Abstinence because of brief intervention alone, provide them pharmacotherapy. So the various options available in our country today are the gums, lozenges and the patches. Nicotine replacement therapy is a safe alternative, and because it is the nicotine which is mainly counters the craving as well as the withdrawal which is happening. There can be some side effects. You have to be aware of that. Take a proper medical history before you advise that. And headache, cough, nausea, hiccups and sore mouth are something which is very common among nicotine replacement therapy users. So when you're using tobacco, 10 dips per day, more than 10 dips a day or less, something which is, I would say, less than 24 cigarettes or bidis a day, you can go on with providing 2 milligram, at least maximum of 15 pieces gums a day. Recommended treatment is 12 weeks. Similarly, if it is more than 25 cigarettes, 4 milligram, maximum to 15 pieces a day, better to be given every hourly, so that the dosage is maintained and the levels are maintained of the nicotine in the body and craving does not happen. Duration ranges between 8 to 12 weeks with gradual reduction. Okay, the average cost of one 10-week treatment would be somewhere between 4,500 to 5,000. If you look at a patch, the nicotine patches are just like transdermal patches applied on your forearm or the back of your chest, on the front of your chest. You can do that. There are 3 doses which are available: 21 milligram, 14 milligram, and 7 milligram. Average cost would range between 7,000 to 8,000. The main problem with the advantage of nicotine patch is continuously provides a desired level of nicotine throughout the day. The only problem with this, people have sleeplessness, and so you need to remove it before you go to bed. Nicotine lozenges have recently come into the market, available in 2 milligram and 4 milligram, a maximum of 15 milligram per day. You need to suck it and keep it. One thing which I would mention again here is nicotine gums need to be, the patient needs to be told how to use it. If you don't schedule the nicotine gum properly on a daily basis, at the same time, if you don't tell him how to chew it, that is, first chew, there will be a tingling sensation, park the gum on the side between the mucosa as well as the gums, and keep it there, and when the tingling sensation goes off, again come back and chew. So repeat this process at least for half an hour and then dispose the gum. So it is very important that people, when have tried using NRT, they say we have tried it, but it is important that you realize that this is the way it has to be done. These could be the common contraindications of NRT use. Keep in mind that acidic beverages before 15 minutes and after 15 minutes of NRT should be avoided. Bupropion is one of the drug of choices, very safe and should be given, but obviously under medical supervision. If you are looking at medical supervision, this is the schedule, the way the drugs are given. The bupropion SR is given. Day 1 to 3, 150 milligram daily. To, there's a loading dose, and goes on to 4 to 6, 150 milligram twice daily, and from day 7 you go on for 12 weeks. And these are the various side effects which could be there, but not necessarily it will be there for everyone. Important that history of seizures is taken. So in case if you want to set up a tobacco cessation clinic, there are many ways of doing it, and it is very inexpensive if you are really wanting to do it. But other than that, you can always have a carbon monoxide monitor and cotinine colorimetric dipsticks or cassettes. So the cost of carbon monoxide monitors would range somewhere between 35,000 to 40,000, and these dipsticks come in a pack of 100, and they are around 50 to 60 rupees per. This is mainly for urine cotinine levels assessment, a very rapid assessment. Within 3 to 5 minutes, you'll be able to clearly qualitatively see whether cotinine is present in the urine or not. So this is a small, overview of how exactly patients are from your OPD area moved to this is a hospital setup, and this is how the patient will reach the tobacco cessation clinic. Through the OPD, through health education, promotional activities, signage is displayed. He goes into oral medicine. There the tobacco user is asked, assessed, and he is asked, advised, and referred to the cessation clinic. If he goes to another department, if he is ready to quit, he is sent to the tobacco cessation clinic, reinforced and sent back there. In case he is not willing, provide health education material. This is a screenshot of how you can do during your first visit, second visit, third visit. If you want to do tobacco cessation, in case you're intervening, use on the first visit, start with 5 A's, use the 5 R's in case the patient is not willing. And second visit, use assess the patient's withdrawal symptoms, his NRT schedule, and check for what is the coping mechanisms using, what are the problems, and then go on, review every visit, and you can, till the third visit or dental treatment is completed, you can complete the follow-ups. And in case following that you want to do it telephonically, you can do it very well. You can do a biochemical analysis or verification of his tobacco use by using the cotinine test which I just told you. So till here we have understood that it is important that we have understood one, tobacco as a problem, nicotine as an addictive substance. We have understood the role of a dental professional, and then we have seen how as dental professionals with behavioral intervention and pharmacotherapy we can intervene. Today we all are talking about cessation. It is not only the Dental Council of India which has been working, but the Ministry and Government of India is also focusing on it. They launched the NTCP, the National Tobacco Control Program, was launched in 2007-8. The NOHP program was relaunched in 2014. The operation guidelines were released in 2018, and today the Dental Council of India has received 301 establishment tobacco cessation clinics across the country. DCI has gone on to also incorporate the assessment of tobacco cessation centers in dental colleges in the inspection pro forma, and regular World No Tobacco Day events are being organized. The Government of India has actually gone on further to establish the National Resource Center at our institute. This resource center is a single point contact for developing, implementing, and advancing dental healthcare professionals' role in tobacco cessation through patient care, research, and capacity building, and integrating into the dental education too. We were successful in organizing the first dental webinar, national level webinar, with almost 287 dental colleges, and the program actually intends to deliver on these aspects. So this is not it. As a dental healthcare professional, you can do much more than this. We've understood at a clinical setting what you can do. Research has a huge scope. Cessation is still open and demands much more evidence from our own country. You can collaborate with various government organizations from the Department of Education, school health programs, and also utilize mobile clinics. We run a program called COPS, which is Community Oral Pre-Cancer Program, wherein we screen patients from the community, refer them in a systematic manner to the hospital. Again, the patient goes back into the community. We continue our contact with the patient, and that's how this program works. You can work towards capacity building, work with the tobacco control community across the country, which is very, very active. This tobacco, national quit line numbers need to be displayed in your own clinics as well as in your hospitals. So these are basically located in Mumbai, located in Bangalore, Delhi, and Guwahati. There's also an M cessation strategy wherein you give a missed call on this particular number and then you get text messages. Talking about text messages, we did an intervention, something called as Dosti, which is dissemination of SMS tobacco intervention. We developed around 42 health promotive messages which were validated scientifically and sent out to our patients, and the results were very promising. Talking about TCC on telephonic counseling, we had a beautiful strategy during the lockdown, and we were very successful in talking to almost 207 of our patients who had registered with us previously. And in a very systematic manner, we conducted this whole study. Develop health awareness material. These are materials which have been developed by our own students and which we use in different parts of Delhi to be circulated for promoting and promotion of not only spitting, not spit. It's not promotion. Basically, to how spitting actually is responsible for COVID transmission. That's what was highlighted through these posters. We've used social media to a lot of success. We have been running this page from 2011 onwards with huge response from the community. We have worked towards tobacco-free workplaces, display of signages. You can have tobacco-free clinics. You can help identify employees working in your own dental setups and provide them assistance and make them quit the habit. At the same time, engage with students who could be targeted by the tobacco industry. So it's important we create tobacco-free workplaces. There are a lot of resources. What I would like to say here is, it is important that we understand that cessation is something which is achievable, which can be performed by all dental care professionals, but certain amount of training is important. This webinar may not be adequate enough to train you, but you need to go on to learn more. You need to learn systematically of how to approach a patient, what records to maintain, what are the various aspects that I need to keep in mind when I'm counseling a patient. Every patient is a new problem, has new issues to cater to. So you need to find out ways, be trained, be oriented, and then implement various behavioral interventions as well as the pharmacotherapy. So institutions like National Institute of Cancer Prevention and Research, Noida, Public Health Foundation of India, Delhi, NIMHANS, Bangaluru, and WHO itself has its e-learning module which are available for free. And there is a huge information available online. Government of India has developed a lot of resource material for you, which is available for your own training and reading materials. So tobacco is a ticking time bomb. We all know that. But we as dental healthcare professionals can stand between the patient as well as tobacco use. We can be a role model for them. We can be, as clinicians, provide adequate care to these patients, educate these patients, and conduct research towards this end that tobacco use can be countered in different ways. We can be a leader in our own communities that we work in. We can be opinion builders. We can form alliances with different organizations, whether they're NGOs, whether they're government departments, and work towards how tobacco cessation can be promoted at different sectors and integrate with different programs that are ongoing currently. So it is important that we teach. That means we train dental healthcare professionals, we educate people in the community, advise all persons using tobacco, counsel and provide adequate dental care to these patients, and work towards harm minimization, that is, among those who have been exposed and unexposed so that they don't start the habit. So dental healthcare professionals have a huge role to play. Today, all the healthcare system actually has been looking up to dental healthcare professionals so they can stand up and provide this, deliver this. During COVID times, we have seen our own fraternity has come out of the way to do a lot of work in COVID response. Similarly, in tobacco cessation, we can and we will contribute. So the choice is yours. We all together can make a difference. On behalf of my Department of Public Health Dentistry and the Mobile Dental Clinic project, I thank you all for your patient hearing. But before I conclude, I really humbly would admit for a certain lapse from my side, that is introduction of our my moderator, esteemed Professor Hiremath sir, who was the former Director cum Dean of Government Dental College Research Institute for Bangalore. He was the chairman of the Ethics Committee at GDC Bangalore. He was the past president of Indian Association of Public Health Dentistry, has authored more than 90 publications, both nationally and internationally, has authored the most successful textbook in the public health dentistry published by the Elsevier publications. He has been instrumental in training, mentoring and guiding for the last more than 3 decades in the specialty of public health dentistry. He has also been the Dean Faculty of Dentistry at Rajiv Gandhi University of Health Sciences and also has received many national and international awards. I am really sorry, sir, that I was not able, I somehow missed out on introducing you, but please accept this apology and I thank you. It is an honor for me to be beside you during this webinar and join you in this effort of promoting tobacco cessation to our dental professional colleagues across the country and worldwide. Thank you so much for your patient hearing. Over to you, sir.
Thank you very much, Vikrant Mohanty. Very nicely presented with a lot of information. And before we go to anything, that there are many questions are there, but unfortunately, on account of positive time, I'll pick up only a few questions, and I'll just ask the questions again.
Sure, sir. Please.
One of the questions is tobacco cessation may new guidelines which is necessary for a dentist to know. Any new guidelines are there for a dentist to know?
Sir, as per Government of India, we have two guidelines already. There are many guidelines for dental professionals which are there, and the World Health Organization (WHO) has its recent guidelines of tobacco cessation, and they can go into the tobacco cessation. You can just type tobacco cessation WHO, and they will have a specific guideline for oral healthcare professionals. So WHO has given two guidelines. You can look at that, and Government of India has already its existing tobacco treatment guidelines which are already available, and you can use those guidelines also. Other than that, I would say the National Resource Center, which is of oral health and tobacco cessation, which I will be currently chairing by next month. I think we would be in full swing, and we will initiate training, and we will also come out with guidelines for dental professionals specifically. That's the whole objective of this National Resource Center. So in this year 2021, we are very hopeful that we will overcome and provide these guidelines to all of you.
Thank you, Dr. Vikrant.
Yes.
Now we'll go to the second question.
Yes.
Smokers are more likely to develop severe disease with COVID-19 compared to the non-smoker. Is it true or false?
It is true, sir. There's adequate evidence that because we all know that the COVID-19 infection basically affects our respiratory system, and smokers who are already have exposed their own lungs and the respiratory system to huge amount of smoke have already altered the normal anatomy of their own system, and they become more prone and are compromised and are more prone to develop infection. There's adequate evidence which has been published during this time. I think it is important that we look into these literature and see that smokers are actually very prone. Even the WHO and other organizations have come out. The ICMR themselves have come out on not only on smoking, but also the ICMR came out with guidelines that spitting. And if you recall, sir, during the lockdown time and even after that, now spitting has become a more bigger offense, and people are being fined for spitting in public places. So previously it was there was a nuisance act which was there, but hardly was ever implemented. But because COVID-19 has brought in a lot of preventive practices, from mouth mask use to hand hygiene to social distancing, and I think spitting is something which needs to be promoted and informed to all our people, because that is the way forward, because preventive practices are the key, mainly important for our way forward, sir.
Yeah, it's very nice. Thank you very much. Now we have one more question there. In a multidisciplinary approach to tobacco cessation, what can be the most convincing point that a dentist can play an important role in helping an individual to quit tobacco?
Sir, can you just repeat the question once again?
In a multidisciplinary approach to tobacco cessation, what can be the most convincing point that a dentist can play an important role in helping an individual to quit tobacco? In multidisciplinary approach.
Yeah, I got it, sir. So what I would suggest is, in case I just give you an example of what we do in our own setting here. So we have a lot of associated hospitals nearby. Like we have the TB chest clinic here. So patients are referred undergoing TB, tuberculosis treatment are referred for dental care here, and at the same time they also referred for cessation services. So first thing first, you need to develop strong referral linkages with your associated hospitals, as well as whether it's outreach camps, whether it is satellite centers, or whether it is associated hospitals. Number one, because with that only the referral linkage will happen. At the same time, the referral has to be two-way. It can't be only from their end. You also could refer any patients for certain amount of medical attention also to them. That's one thing you have to keep in mind. Second thing is, most of these patients who are referred with certain amount of medical findings do have a huge need for dental treatment. So one, as a dental healthcare professional, you could cater to their, provide them dental care. And when they see the best part about dental care is objective in nature. Mainly the difference can be felt immediately. Other health related improvements take time to happen. But dental healthcare, can equally, once the treatment is done, immediately the patient starts seeing the differences. So automatically it is relatable. And the way you provide, whether it is primary level, whether it is secondary level, whether it is tertiary level, all the levels of care that you provide are important and instrumental in this multidisciplinary approach. Whether you rehabilitate the lost tooth because of his parodontally compromised in case of a tuberculosis patient or a diabetes patient, or you provide routine scaling, or you provide routine counseling. All these levels of care are very important in case of a multidisciplinary approach.
Very nicely answered, Dr. Vikrant. Now, one simple thing is, what about herbal tobacco? How effective is this?
Yeah, herbal tobacco, sir. I've heard I've heard of one of the it's a product called as Herby Chew that I've heard, which has been developed by one of the CSIR labs in Lucknow. I'm not very sure about this particular herbal tobacco which has been asked, but that Herby Chew which was mainly developed with this concept that it was scientifically developed mainly for patients with smokeless tobacco use who actually want to quit. So it is mainly for replacing the chewing habit. So they're still chewing, but they're chewing something which is totally different. So this is something which I know. When it comes to herbal tobacco, there are many cigarette companies or people have come up with alternatives which are healthy or which are safer. But I don't think so they are safe, and it should not be promoted in any way.
Yeah. Okay. The one more interesting question is here. Since nicotine is a basic component that keeps the consumers addicted, is it actually ethical to get addicts of tobacco and hook them onto the nicotine supplements, thereby converting the addiction market from tobacco to the one with nicotine as an OTC product?
Yeah, I understand. So this is something which is regularly asked and discussed. See, to be very frank, it is very simple for us to understand because we know that nicotine. We are not just talking about nicotine and smoke or smokeless tobacco and nicotine in the gum or the patch. So the first thing is the nicotine is a part of the gamut of toxins which are released from smoke or whether it is a smokeless product. It is, we all know that there are 7,000. I have not got into much details, but there are 7,000 chemicals which are there in a cigarette, and out of these 7,000, almost 40 plus are known carcinogens, and we know that these are all part. And out of this, nicotine is just one. Okay, now when we remove nicotine from that and talk about just nicotine per se, the delivery of nicotine in cigarette as well as smokeless products is much quicker as compared to what we are delivering through the gum or the patch. That's the second point. The third point is that the patch and the gum actually provides a very low dose of nicotine as compared to what these people provide. And the sustainability of these is, in this, because as soon as the nicotine goes down, the demand increases. So what we do, that's why what I was just telling you when I was talking about NRT gums is that you have to give it every hourly. When you give it every hourly, you are able to maintain. And the last thing I would say is these nicotine replacement therapy is given in a strategic manner. It is planned initially based on the dependence, and then there is gradual tapering. It is something which has to be informed the patient that this is a medication and has to stop because this is helping you overcome craving. So these are my takes on what nicotine, how you can counter these kind of questions. That nicotine is addictive in a cigarette as well as smokeless tobacco. At the same time, you're providing nicotine from gums. It is more of a medication. Yes, it is an OTC drug. We have to be careful, and even the pharmacists need to be informed, or the various counters need to be informed at this, and they give in proper instructions of its use. The main problem is people do not use NRT the way it is supposed to be used, and that is why they fail in their attempts. And that is where we as dental healthcare professionals should contribute in understanding this thing and communicating this thing to the patients.
Yeah, that's very much true. What you explained is an appropriate take. Now we'll go into the next question.
Yes, sir.
How do you diagnose whether he is a physiological dependent or behavioral dependent on tobacco consumption?
Okay, so the question is whether he is physiological dependent or behavioral. So that's what
physiological dependent or behavioral dependent, how you are going to diagnose when the patient visits you?
Yeah, so I've already told you with regard to physiological dependence, which is mainly the nicotine aspect, the nicotine as a component that we are taking. We use these scales. We use the heaviness of smoking index. We use Fagerstrom scales. Fagerstrom scales are available both for smokeless as well as smokers. So you can use that and classify the patient into highly dependent, moderately dependent, or else as low dependence. When I talk about behavioral component, that's what we do. It is very important that you actually take these information, whether you take his, for example, when we have our own worksheet, which we when we take the patient's socio-demographic information, we take his number of working hours, we take his type of work, we take his income, we take his total number of dependents, we talk about his what are the various environmental cues that are there, and then on the basis of that you get this basic information. It is very important for us to note down this information and use this information during. So we ask these questions: do you buy tobacco in bulk, or do you buy it once in a while? Do you buy it from the same shop, or do you buy it from different shops? So there are patterns. One thing which I missed out to talk about is something called as tobacco diary. So we developed this concept of tobacco diary because every individual has a pattern of use, whether it is his consumption pattern, whether it is his purchase pattern, whether it is his overall pattern. So it is important that you understand every patient's pattern. So for that, you need to, just like how we have a diet diary, we have to maintain this tobacco diary. A patient, whenever he consumes or doesn't consume or have urges, he notes down this when the patient is a part of the treatment program. Otherwise also, when he is visiting you, you need to take down this information and reinforce using this information that you have.
Thank you, Dr. Mohanty. And though it's a very simple question, but I'm surprised one second year BDA student is asking a question. Yes. He says that I'm coming across many rickshawalas asking me to help with their tobacco addiction. What can I do to help them to quit the tobacco smoking?
Well, I think, sir, I totally understand this is something which can happen to all of us on a day-to-day basis. But yes, first, please see to it if you can refer them to your hospital, it will be better, because you need to get a detailed history of these patients. Patients offhand should not be treated. They should be called in, properly examined, properly assessed, and proper advice needs to be provided. I know people with daily wage and people background from the lower socioeconomic status have difficulties in reaching to centers because they will lose their daily wage. But it is important that they are motivated to come to the hospitals or the clinics where they can be provided care.
Okay, that's fine. It was very interesting because second degree student was so much interested in your talk, and he came across with this question. Now there are many questions on the pause of paucity. I would like to ask the last question only.
Yes, sir.
What are the challenges a dental professional person can face with tobacco assistance programs?
So one of the most important challenges is like when I told physiological as well as the the behavioral component. We need to undergo proper. First thing is we have to undergo training. Till the time you're not trained properly, you will not be able to understand the whole understand the whole problem as a whole. You will be looking only at different aspects. So as a result of which, when you're not able to holistically identify these things, you will not be able to plan a solution for the problem, and ultimately will fail in the effort. So it is important, first get trained. Number one, once you're trained, how do you integrate into your daily dental care? Whether you're doing it in a clinical setting, whether you're doing it in a hospital setting or an institutional setting. It is important that everybody is sensitized about what and when what their roles are. So again, sensitizing each checkpoint is very important. When you're talking about your waiting area, that also needs to be developed. When you're talking about your oral medicine diagnosis department, they also have to be oriented, trained to provide certain level of intervention there. So when they refer, then automatically the tobacco cessation clinic starts its activity. Other departments also need to join in this and have to be reinforcing at every point of contact with the patient. This is when you're talking about an institutional setting. So this is what you have to train yourself first, sensitize every checkpoint that you have, and work in a way time, because many times patients don't have time for these kind of care. So what they do is they just tell that you do it, I will go to the cessation clinic separately, but you please do my treatment first. So what you should do is you should utilize the chairside time again to counsel the patient. You may not actually, that's what I'm trying to tell, sir. In different settings, we have different challenges. So keeping these challenges in mind is very important. Identifying challenges like lack of time, lack of training, lack of financial reimbursement for these kind of interventions. So it is important that you can develop a kind of a comprehensive plan where scaling and cessation could be integrated and the patient could be charged for that. So you could look at different ways wherein you can provide, once you're trained, provide these things. And one-time training is not enough. Repeated training, reinforcements are very essential. So please take out more time to, beyond this webinar, to actually get yourself trained, get yourself certified, and then complement your treatment wherever it is possible. While you're giving an implant, whether you're providing periodontal therapy, whether you're doing an extraction, whether you're doing just counseling, all these things would require and intervene. During these treatments, you can intervene and provide cessation. The only thing is we are having a mindset which is very fixated. We think that doing cessation means I have to sit one-to-one and do it all the time. It is not necessary. It can be a combination of doing one-to-one sessions with chair side time. So it is all these challenges. Every new intervention has their own set of challenges. It is important that we identify them. Number two, work towards overcoming them. So this is my take, sir. If you can add to all this, I would be more than happy, sir.
Thank you very much, Vikrant. It was a wonderful presentation.
Thank you so much.
Believe me, it was packed with a lot of information on evidence and practical solution with regard to importance of tobacco cessation in the present scenario. You also nicely explained the strength, opportunities, and challenges in managing the role of dental professionals and tobacco cessation. Very aptly covered the behavioral intervention on tobacco cessation with a lot of emphasis on pharmacotherapy. And I would like to say that on the whole, it was a simply wonderful presentation with a lot of information. You took us on a new journey of learning certain issues with the challenges which are going to be faced by most of us. So thank you very much, Vikrant Mohanty. You have nicely covered most of the things.
Thank you so much, sir. But before I sign off from here, sir, I would kindly accept my apologies for missing out on introducing you.
No, it's not at all an issue at all. Please do not say that at all. It's all part and parcel of the protocol, nothing else. Absolutely fine.
I really appreciate your support.
No, don't feel bad about it.
Yes, sir.
It's fine. It's very good. I know it was a nice time. Now coming to the before the ending the session, I would like to announce again, and with a lot of appreciation and recognition, that there are 5 dental colleges who had the highest attendance in the last webinars. So starting with the Savita Dental College that is from Chennai, and Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, Jananayak Devilal Dental College, Sirsa, MGM Dental College and Hospital, Navi Mumbai, and lastly, Sharad Pawar Dental College, Varda. Now herewith, we are requesting, and I am personally requesting also that in the coming webinars also, kindly attend in the large strength and give a lot of encouragement for conducting and taking these webinars forward. At the same time, we would like to thank the remaining colleges also who have given a full strength for making these webinars more useful and a scientific learning on this particular webinar series. Now, I would like to announce that there is a coming webinar which is there on 17th of January 2021, next Sunday. The topic is Evidence to Deep Learning, the new paradigm in orthodontics. The presenter is Professor Anmol Khala, a Professor Emeritus, Distinguished Professor and Advisor CIDS, Associate Director and Advisor, Maxwell Healthcare, Chief Architect and Co-founder, Nadvia and Chairman, Scientific India International Orthodontics Symposium 2020. And it is going to be moderated by Dr. Sri Krishna Chalsans, a President-elect, Indian Orthodontic Society, Executive Committee member, Asian Pacific Orthodontic Society, Council member, and World Federation of Orthodontics. So I request all of you to attend in a full strength and make this coming webinar more successful and more useful. Now, coming to the end of the program, I take this opportunity that my sincere thanks to all of you for having attended this webinar in full strength with a lot of enthusiasm and contributing for the successful webinar series. It goes with a deep appreciation. Once again, I take the opportunity to convey my gratitude and thanks to the Honorable President, Dr. Bharat Shetty, Secretary, Deputy Secretary, Executive Committee members, DCI members, and the most importantly, the technical team behind this particular program, which made such a wonderful cooperation, helping making the programs very successful. And my sincere thanks and special thanks goes to Dr. Virendra Goyal, Mr. Mukesh, Deputy Secretary, and entire wonderful technical team. Without their support, help, and understanding, this would not have been successful at all. Thank you once again from the bottom of my heart. Lastly, wishing you all very best in your future endeavors. And I'm sure the new year will bring new avenues, new hopes, and new achievements. Wishing you very happy, healthy, and fulfilling New Year 2021. Namaskar, Jai Hind. Thank you very much.
Thank you very much, sir. Thank you very much.